everybody. We're going to call this month's Board of Health meeting to order, and then I'm going to make a few adjustments to uh, use time efficiently here. Item A is the official notice of the public meeting, which we have here. For the record, a copy of the Open Meetings Act is located, it's been moved, I think it's on the uh, northwest wall in the back, if anybody wants to look at that. And now we will go to roll call.
Here.
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 Item 2 is approval of the minutes. Is there a motion to approve the minutes from August?
So moved?
Motion by Weiss. Is there a second? Second by Espinosa. Roll call. Yes.
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 Item 3 is public comment. Is there any public comment on any Board of Health related item that is not listed officially on the agenda? Is there any public comment at this time? Seeing none, now is where we're going to make a little bit of change. So my understanding is there is a line on I-80 with some issues there. So I'm going to move a brief exec session that we're going to have. That will take us less than 5 minutes here. Hopefully that buys time for people to get back in. And when that, we will come back, and then we will go into some items that are here from some degree. So with that, I'd like to ask, I'm going to move the executive session up and ask for a motion to go into executive session for personnel matters.
So moved.
Motion by Wise, is there a second? Second by Wilkin. Roll call.
Yes.
Yes. Okay. We'll be about 5-10 minutes. Thank you. there a motion to return out of executive session? Motion by Wilkins, is there a second?
Second?
Second by Festerson. Roll call.
Rogers,
Yes.
Weiss. Festerson.
Yes.
Wade, Wilkin. Espinoza.
Okay. Everybody on Zoom can hear, I'm assuming? Okay. Let's go down to item 4, which is approval of the action items. For the month, there are 5 items. Is there a motion to approve items A through E?
So moved.
Motion by Wilkins, is there a second?
Second?
Second by Weiss. Any questions? Roll call.
Festerson,
Yes.
Rogers,
Yes.
Wilkin,
Yes.
Espinoza. Weiss.
Item 5, Health Director's Report and Issues Discussion. Dr. Hughes.
Good morning, and thank you for the extra time for the stopped interstate this morning. I don't have too much to update you on this month, and I know that we have 3 presentations today, so I want to make sure we give them plenty of time. But I did want to give you just a very quick update on some building things that we're taking care of. We are in the process right now of working with our other partners that share our building to update our camera system, to RFP out our security team, and also we are in the middle of getting panic buttons for several locations within our building. During a security walkthrough, it was identified that we basically did not have security up to par, and so we are going with the same camera company that the Election Commission and I think the Sheriff's Office uses. And so that's in process, and we're very happy that we're going to be able to provide some extra coverage for our parking lots. We have had incidents out there before, so wanted to make sure that everybody who comes to our building can do so and feel safe. I don't have any information yet about which security company will win that RFP. I think we actually have to go back to a rebid, and other than that, we are moving forward with our new space that General Assistance was able to give over to us. There are some renovations that need to happen to that area, and those will be happening in the next couple of months. Basically, there's a wall that needs to come down, and other than that, we're getting those offices ready to be filled with employees. So we're really, really excited to be able to expand and make some extra room for our incoming employees that we'll be hiring through our infrastructure grant, and being able to maybe do a little bit better job of how we group our employees within their sections throughout the department. And so that's pretty exciting. It's been slow, but we're moving forward with that. I also wanted to just let you know that because this seems to be a very popular subject in the community, we were awarded CDC money to address overdose, and we are so excited. This is a grant that's been around for a little while, but typically has only been open to states. This year they opened it up to local health departments and local organizations. We did apply for that along with a variety of people from our community, and very happy to announce that we were awarded that in the amount of, I think it was $890,000. That grant goes over 5 years, and it's going to enable us to do a better job of really looking at assessing and addressing overdose within our community, and we'll be partnering with some other agencies within our community to do that, and we're very excited about that work. But the team worked really hard on that grant, and it took a lot of different collaborations to make that happen, so we're really proud of them and grateful. Other than that, I don't have any other announcements for you today. Any questions for me?
Which division does that CDC grant go to?
The CDC grant will be in Leah Casaneves, and it will be sitting with Patty Falcone in the health promotion program. And Leah will be out for a little while, but she'll be back about mid-November.
Any other questions? All right,
All right,
Thank you, Dr.
thank you
Lewis.
so much.
all right. We'll go to item 6 in presentations, and this month it's the Children's Hospital Community Benefit Report. So if they want to set up, I'll give them time. Go from there. Good morning.
Do I need to share screen with the Zoom, or is it already?
Share screen. And you pick up yours. Just move the window where it's at.
Please move the window away from the shared application.
I don't know why it's not sharing. Would you, let me get this to share. She clicked on the shared screen and picked it up. And it said, move application away from some. So I know that maybe you have to expand this, maybe, before it pops up on there. Well, open this. To gallery. Why is it not opening online?
I'm gonna just stop sharing. Is this on yours?
Yeah, that's it.
Okay.
See? And now
Sharing.
Oh, do you have it? Just have to hit slideshow.
Yeah.
Okay.
So once you hit slideshow, it should be presenting now.
Hit slideshow?
Yeah.
Sorry, where's that?
Right there. And then there you
Oh,
go.
there we go. Okay, thank you. Okay, well, good morning, everyone. My name is Jennifer Benson. I am the Community Benefit Manager for Children's Hospital and Medical Center, and Holly Dingman, who is our Director of Community Health and Advocacy, is also here with me today. So we are excited to talk to you a little bit about our 2021 Community Benefit Expense Report, and then also some of the work that our team has been doing over the past year. Oh, sorry. Is that better? Okay, so we'll start with the Community Benefit Expense Report. And our most recent Community Benefit Report is from 2021, where the total expenditures were about $169 million. At Children's, we separate our community benefit expenses into 3 broad buckets. Broader community health is inclusive of our sponsorships, our subsidized health services, our health professions education, and our pediatric research. Uncompensated care includes our financial assistance, our unreimbursed Medicaid, and our bad debt. And then community programs and services includes our health, community health programs, as well as the cost to manage the community benefit operations of the organization. So we've distributed some community benefit reports here in the room, but then we also, if you're online, you can access the community benefit report by going to children'somaha.org/community-benefit. Thank you. So this is a picture of our community benefit expenses over the past 5 years. You can see that the largest increase from 2020 to 2021 was in uncompensated care. We saw an increase in our number of patients and number of visits as we rebounded from COVID, which is likely some of that increase in uncompensated care. Financial assistance from 2020 to 2021 was pretty even, and our unreimbursed Medicaid is largely the difference between the was largely responsible for that jump from 2020 to 2021. And then this last slide that I have, we like at Children's to start our community benefit steering committees and any of our meetings related to community benefit with a little, what I like to call community benefit moment. And so this is just a moment about our Caring Contacts program. And this is a program that will be featured in our upcoming community benefit report for 2022, which is actually due out late in 2023. And our Caring Contacts program began in May of 2020 in the emergency department. Each patient who was seen in the ED who received a mental health assessment received 6 handwritten notes from the social worker who conducted their mental health assessment over the course of a year. And the notes offer engagement and support. Caring Contacts has enrolled more than 500 patients since it began in May of 2020, and we have no reports of completed suicide for the patients enrolled. Patients often write back, and this note here are some photos of from a patient who had written back to their social worker after receiving some notes. So that is just a quick summary of the community benefit report piece. Are there any questions related to community benefit that I could answer?
Can you speak a little bit to the areas of focus in your community benefit and what health needs assessments you're working on?
Sure. Actually, I'm going to invite Holly Dingman up to share more about that information. So
It's coming next, huh?
Holly?
That was a perfect setup.
All right.
Thank you.
Great, and we can address all questions too if you have processed the community benefit numbers, but I get to tell you about the process that we've been taking with our implementation strategy plan. Just want to thank you for the invitation to be here and to give this report. I'm Holly Dingman. I direct the Community Health and Advocacy team at Children's. I have an amazing team and just want to acknowledge Jeannie Weiss, who's our Community Health Strategy Leader, Megan Connolly, who's our VP of Community Health and Advocacy, and key drivers of this work and good contacts for all of you as you start to think about how you might connect and we might connect further on this. We are about halfway through our implementation strategy plan, and we have advanced 4 new priorities that we told you about a year ago is when we were here: pediatric mental wellness, healthy housing, food security, financial stability. As we've done our work, it was really important to us to take a step back and say, who are we as a children's hospital? What assets do we bring to this work? And so this is a slide we've been using in a lot of our internal and community conversations. And I just want to highlight that we see 150,000 plus children every year through our services. We are the largest Medicaid provider of children in the state of Nebraska. 1 in 4 Nebraska kids are seen through Children's. We are the 2nd largest employer of clinical social workers. And to do this work, we have a lot of team members, and so we have 3,500 plus employees. We are also, this is important, celebrating this year our 75th anniversary. Children's opened doors in 1948 as a response to the polio epidemic. And so in a couple weeks, you'll hear some media news from Children's about our 75 years. This is an outline of the process that we've been taking. So as I mentioned, we brought forward 4 new priorities. We had been in the work of pediatric mental wellness, but the social determinant of health work was relatively new for us. So in 2020, we started to organize a due diligence process, literature review, talking to other peer hospitals, doing an inventory of community efforts and leaders in the space. 34 promising options were identified for our work, and in January through March, we convened 3 community stakeholder meetings, bringing those promising options for financial stability, healthy housing, food security, in front of 24 community organizations to give us some feedback. How can children's be additive? What, leveraging our strengths, what would make sense for children's to be in this space? We brought those community recommendations forward into internal committee discussions with our action teams. We have ISP steering committee and community benefit steering committee, and we started to narrow further on those options. Lean business models were developed this summer, and we just brought them to an internal steering group at the end of August. So you get a sneak peek of fresh recommendations that we're still bringing to children's leadership for final review. I want to acknowledge that as we did our due diligence and started to look at promising options, we acknowledged that there are a continuum of strategies that we could employ from downstream to midstream to upstream. We really focused community health and advocacy efforts in that mid and upstream. We wanted a portfolio that reflected opportunities across the continuum, and that clinical care is downstream, where we impact individual child health, and our promising options complement that. Here are the 6 promising options that have come forward for children's. So workforce and youth development helps us focus on workforce pipeline development. This is to identify comprehensive and strategic approaches to diversify and expand our workforce. One of the new initiatives at Children's is Pathways to Healthcare. We provide high school students with paid internship opportunities on campus. They get to rotate through multiple clinical experiences, shadow our professional staff, and are learning the various aspects of a health system and professional development opportunities. Employer-sponsored childcare, we're going to dig in and develop a strategic approach to support and assist children's workforce to attain and retain reliable childcare. This can result in improved stability with our own staff's financial health. And I think it's important to acknowledge that the chamber and community were really excited and adamant that children step forward in this direction, knowing that there's a child care crisis and recognizing that children's can be a leader in this space and setting an example. Board development and representation. We see this as a low-hanging fruit but impactful opportunity to support children's employees and strategically have them represent children's on boards with aligned missions. So we want to commit time and talent into nonprofit organizations, but also ensure that those team members are prepared for that board service, that they understand the roles and responsibilities and can bring forward all those assets that come with children's. Sustained food access. We see an important opportunity to target enrollment assistance for SNAP and WIC. Medicaid families are automatically qualified for SNAP, yet only 20% of eligible SNAP participants do not participate. So if we leave the application to the families, they have about a 40% success rate. If we help those families apply for SNAP, it doubles their participation rate. And WIC is similar, however, with a lower participation rate. About 50% of eligible women, infants, and children participate in WIC. So we are looking at a community health worker model to reach out to families and enroll them in SNAP and WIC. Financial literacy. We would like to explore and institute a medical financial partnership to improve financial stability of our patients and families. This really focuses on strengthening pathways of referral and providing access to financial literacy education. Home remediation and accessibility leverages partnerships to keep children healthy and safe at home, In particular, we looked at 2 high-risk populations at children with special health care needs and asthma patients. The community really encouraged us to lean into these populations, knowing that this is where we could be most helpful. We'll be focusing this work on education, advocacy, and connecting resources through medical legal partnership. The last 3 promising options here, sustained food access, financial literacy, home remediation, and accessibility, all explore the use of community health workers to develop proactive models, helping families get the resources that they need. Again, this is a fresh list of narrowed options. We are still taking through our internal leadership channels, and we'll be moving into active action planning phase, which is where we'll finalize the scope of work and our partners. I keep right-clicking. I want to mention the progress we're making and the process we're starting back up. So 3-year cycles are short. You know this. Why we couldn't be on a 5-year cycle like the health department, I'm not sure. But our CHNA cycle is 3 years. So we are already starting to convene a core team. We are finalizing our survey questions with PRC, who is our survey partner. We'll also be adding focus groups for our 2024 survey to capture youth and caregiver voices. This winter, we'll be going into the field with our survey, both the telephone survey and the stakeholder survey, which is a little bit ahead of schedule, and we're pleased with that. And come spring, we will be co-hosting with community organizations some listening sessions. We recognize that our needs assessment doesn't bring all voices forward. And so in particular, we'd like to bring forward immigrant and refugee voices, foster youth, homeless or housing insecure, and LGBTQ+. We're interested in both youth and caregiver voice. A year from now, we will have some data sharing, hopefully, some preliminary data if we get invited back to present. So the PRC report, the listening session report, will all be brought to the board, Children's Board, in November and must be posted by the end of next year. I want to acknowledge the efforts that we've been making internally at Children's for Health Equity. Our work this last year is really focused on internal infrastructure building. Health equity is embedded into 2 goals of our strategic plan, our advocacy goal and our workforce goal. We're standardizing language by adopting the National Institute of Health's definition of underrepresented child populations. This is a definition we're infusing into communication, messaging, strategic planning, data collection, and reporting. This summer, we stood up a health equity steering committee with these 3 components, representing team, patient, and community. It's a cross-departmental representation, and the intention is to coordinate, guide, and implement health equity efforts throughout Children's enterprise. This steering committee will help Children's also ensure our organizational compliance with the Joint Commission and CMS requirements for equity. We have also been and will continue to be on a long learning journey. We've participated in a national racial equity and healthcare learning collaborative. We are participating in the Institute for Healthcare Improvements Pursuing Equity Learning Collaborative that you're familiar with. And we're also participating in the Nebraska Hospital Association's Health Equity SDOH Quality Initiative Task Force. And as we started, Jen gave a nice community benefit moment with our caring contacts. Pediatric mental wellness is a priority at Children's. I just want to give a very high-level overview of what's happening in behavioral health and pediatric mental wellness. This is intended to be a teaser. We hope you invite us back to give more information. But a lot of work is happening across the continuum of care. We have launched COPE, which is a program that aims at strengthening skills and knowledge of primary care providers across the state. There are 4,000 primary care providers. We know they are a frontline team for the children across the state in dealing with their mental health. So we've completed our first cohort. We trained 45 PCPs. Half came from rural Nebraska, which we were really pleased about. Our next training is scheduled in just about a month in Kearney. COPE also has rapid consults part of the design, so any PCP serving children can have access to adolescent and child psychiatrists as needed. We have deepened our work in school-based pediatric mental health initiatives.
Will you say what a PCP is, just in case, again?
Yes, thank you. Primary care provider.
Okay.
So our school-based pediatric mental health initiatives have focused on professional development and professional partnerships through the Nebraska Social Work Association and School Counselor Association. We're also really interested in building up peer-to-peer support programs in schools and the infrastructure that's needed for that. Our behavioral health urgent care is in the works. This will provide families immediate assessment and treatment on a walk-in basis for the treatment of acute behavioral health conditions. The goal is to, again, reduce the number of kiddos that we're seeing in our emergency room and just supporting greater mental health. Construction of the Kearney Mental Health Urgent Care is starting this month, and it will be open in January. It's right across the street from CHI, Good Samaritan, and in the same building as our Children's Physician Primary Care Clinic. The second behavioral health urgent care will open when our Behavioral Health and Wellness Center opens. We just broke ground on the 7 acres that sit right west of our main campus on 84th and Dodge. This will provide a very comprehensive scope of service from including a primary care clinic to, again, normalize behavioral health as part of total health care to intensive inpatient services. Again, just a teaser to hopefully get you interested in talking to one of us more about this or having us come back. That is the update from Children's. Any questions? Yes.
Did I hear you say 1 in 4 children in Nebraska access the children's hospital services?
Correct.
What are the other locations in addition to Kearney and Omaha for children's
Yes.
across the state?
So we have, I believe it's 14 specialty clinics sprinkled around the region. We've got Sioux City, Lincoln, Kearney. Our primary care network is predominantly here in the metro, but we do have a primary care clinic in Kearney. Our home health services have a 60-mile radius around Lincoln and Omaha. Our trauma transport teams go all across the state. So when you look at a map of where kiddos are coming from, every county, sometimes one is not included in the map every year, but every county we see kiddos coming to Children's.
Thank you.
Mm-hmm.
So unlike other health systems, you're not reliant upon Medicare, but you are heavily reliant upon Medicaid, as you pointed out, and I'm glad you did point that out. The largest increase in your community benefit numbers, though, is coming from uncompensated care, even though we've had Medicaid expansion, right? I'm interested in your observations about why that has occurred, even though we did finally expand Medicaid in Nebraska.
Jen, do you have thoughts on this?
Yeah, let's go back to that slide if we can. Take a look at it.
Mm-hmm.
So yes, so the uncompensated care, that teal blue is where the Medicaid reimbursement is. And I think there are a few things that cause the difference there from 2020 to 2021. We saw our patients served increase. So 2020 had a fairly low patient volume because of COVID, and so we started seeing more patients and more visits again. So we had more to bill. There also, at times, there is kind of a difference between when the timing of the billing and the timing of when things get paid. So you can see over the course of about 3 years, the Medicaid was between about $35 and $45 million, but then in 2017 and 2021, the uncompensated care bucket was at 63 million and 73 million. So sometimes there's some timing issue there too. I think we'll know more about what caused the increase in 2021 when we're able to look at 2022.
Okay. And then any observations about Medicaid redetermination as well? That's unfolding right now, but I'm sure that's a concern for you.
It's a big concern, yes, and I would say our care coordination team is doing great frontline work with the families, having those conversations as we interact with families. It's a big challenge for the state. It's a 14-month period for redetermining, 350,000 Medicaid enrollees. So that's just such a large volume. We are digging into what that looks like at Children's. We don't have data on that yet. We're curious about it. We're also curious about it from the state perspective of how many of those families are re-enrolling, how many had secondary insurance options that, because of the public health emergency could still access Medicaid, but now, have insurance support otherwise. So yes, we are in the thick of it, and I would say the state is doing a great job. I've also heard really strong efforts across community, the FQHCs, HCAN, which is the Healthcare Association of Nebraska, doing a lot of work. We did a webinar for schools, so schools could be part of that conversation with their students. It takes all voices to say, hey, we need to help our families get re-enrolled.
Yeah, I think that's right. The more we can highlight that issue, the better, because I think a lot of folks who may be coming off the rolls are doing so for procedural reasons rather than not qualifying, right?
Yes.
Yeah. Good. Thank you.
Yeah.
A question in regards to your workforce development and the great use that you have with community healthcare workers. Does your system have an in-house training for community health workers, or do you work with educational partners in the community?
Yes, so that is yet to be determined. No, we do not have an internal training. So yes, we will be partnering up with a partner to do that.
I have a question.
Yes.
I actually have a few.
Great.
Also about the workforce and youth development, you mentioned the Pathways to Healthcare program. Is that current?
That's current.
And then I just have questions about how the youth are recruited to participate, and if there's any efforts to focus on underrepresented minorities because of the disparity in healthcare providers of color, and then if they're paid.
Yes, all really good questions. Our Human Resource Department is leading that program. So I cannot speak to our recruitment strategies, but I do know that there's a focus on diversity. And yes, the interns are paid. Jeannie, would you like to speak to that?
I can add to that for recruitment. They partnered with Latino Center of the Midlands, College Possible, Empowerment Network, etc. So many youth-facing organizations. I think there were 5 or 6 in total. And this past summer was our pilot year. We had 20 students in our pilot year, and 100% of those students were of color.
Awesome. Sorry, I have a few more questions. Is that okay?
Oh, yeah.
Okay. You mentioned in the timeline that you also had, you're planning to do focus groups with youth and caregivers, and then you also mentioned later on you're going to do listening sessions. How are those different from the focus groups?
They're the same. They're the same. Yeah.
Okay.
So the focus group is more of the academic term, and really, the intention is to be in space listening, but collecting that qualitative data to complement our PRC data.
Okay, thank you.
Mhm.
Sorry, y'all, a couple more questions. And then you mentioned for the health equity that you were participating in a number of task force, collaboratives, et cetera. Are these local, and then are you planning to participate, or are you participating in training that's more on the national level to grasp what other people are doing in the country?
Yes. Yes and yes. So we're participating locally and in a couple of national cohorts.
Okay,
Mm-hmm.
last question.
Mm-hmm.
You mentioned the school-based pediatric mental health initiatives and that you are partnering with a number of professional partnerships, and I think Hope Squad, it says here. Just curious how you're leveraging those partnerships to inform what you're doing for the school-based initiative for mental
Yeah.
health.
That's a great question. One of our key partners in school health is the Nebraska Department of Education. Children's school health team is an extension of the Department of Education's team. So we have both an ear internally of what's happening within the State Department, and then those professional networks, our team members serve on the boards. We often turn to those professional networks to say, what sort of professional needs are here, and work with those organizations to bring in speakers, bring in trainings, and reach their members.
Thank you. That's
Mhm.
all I have.
Great.
Okay, let me ask one last workforce question. So
Great.
everybody asks, and I'm just trying to frame it up. So your workforce involvement is likely like early engagement of trying to get people. It seems like all your answers are like your workforce is early engagement and exposure in trying to get people get youth exposed to the field, the early up ramp part, because that's what I was.
Correct.
Okay. So that exposure piece is not only for I'm assuming that's the first two, the workforce and youth development, and then the employer-sponsored childcare. That's exposure and just early enhancement and tease to get them in the field.
Yes.
Okay.
I would say we weren't quite sure about the childcare component yet, because we need to do some internal assessment and planning.
Okay.
But yes, the start of that is internal awareness and exposure. Mhm.
Okay. I noted when you said the last three, you were sustaining food access, financial literacy, home remediation, accessibility. You used the term. You were exploring community health workers. Do you mean by explore ramping up, or using them in a different way, or are they just coming in new?
Yeah, really good question. We currently do not employ any community health workers at Children's. So this would be developing community health worker model to complement our large care coordination team and the work that we're doing in the community.
Okay.
So that's the exploration that needs to be done to place those community health workers appropriately in a role that does complement the work that we do in reaching families.
I'm just curious, what's the number you think you're going to need to get in to ramp up for those? What's the approximate range you think you need?
I don't think we've quite projected that out yet, where our business models have put forward 2 community health worker interns to start, almost as a case proof of concept.
Okay. The last question that you invited it, but I'm definitely looking forward to when you come back. I'm just curious, your pediatric mental, the wellness, and the term may have evolved for something else, but pediatric mental wellness, is that just evolved and built out of the growing conversation that's going on about mental health, or are you preparing for something out of COVID, or are you seeing something that's, because this is the first time I've heard the term pediatric mental illness. What are you seeing that's got you going there?
So we intentionally wanted a very broad definition encompassing both prevention,
Okay.
those prevention pieces, in addition to the care and the systems surrounding care. So wellness encompasses all of the above for pediatric mental health.
So I'm just assuming when I'm hearing the term pediatric mental wellness, I'm assuming pediatric goes from what? Birth to, from what age?
Birth to
18?
21 is how we define it.
21. Okay. So that's from everything in real early stage to just a kid's exposure and environment and what triggers
Yes.
to actually thing.
Yep.
It evolves over time. Okay.
It can include parent attachment, parent-child attachment. Yes, the health of the mental health status of just children at different stages, and then the considerations of how do you promote and protect that mental health at the different stages.
Okay. Okay. All righty. Yeah, I'm looking. I didn't see anything right now.
Can I ask a question?
Go ahead.
For the Pathways program, what age, like for high school, is that just juniors and seniors, or who's eligible for that?
Yes, juniors and seniors.
Okay. And has there been any thought about or consideration of maybe doing like a youth peer educator, almost like a youth community health worker that would partner with one of the community health workers if someone was interested in something like that?
I have not heard that idea, but I love that idea. I'm making note. Thank you.
You done, Dr. Jones? Okay, got it. I don't see anything else in the chat. All righty, thank you all. I would have to say your at least personally, I've noted just your presentation every year gets better. I appreciate the information.
Thank you. Appreciate it. And we look forward to continuing our important health equity work together. And any of this, we invite more conversation. So thank you for the opportunity.
Thank you, and look forward to the next year whenever you get the other piece evolved. Thank you all.
Great.
We'll move to item B and the Health Equity Division update.
Good morning, members of the board. I'm Jamin Johnson, Division Chief of Health Equity and Planning. I might propose, I'm going to go really fast so that I can kind of punt to Akshay to give him the maximum amount of time to present to you today. I want to give just a quick update and overview of, let me share my screen, of where the Division of Health Equity and Planning sits currently, and then I think what Akshay has compiled, I think, is timely and important for y'all. Okay. I wanted to quickly just provide a brief overview as we continue to restructure and form the division, some of the programmatic functions that have been redistributed from other parts of the health department into the division. So obviously the primary focus and responsibility where I see myself when I think of my role and responsibility, it is to continue to serve as the health equity advisor and to provide that lens and perspective in every room and conversation that myself or the members of my team find ourselves. Some of the areas where we've focused some of our attention over the past year or so really do center around language access. We identified as a department some areas of, I guess, constructive growth when it comes to language access in a few ways. One, when we think about the ways in which we are poised to communicate information to our community in a timely manner, I think the Knox Creek fire was a great example of us recognizing an opportunity for us to learn and develop community relationships that allows for us to put out timely public health emergency communications in the preferred languages of the communities we serve. That's a partnership. We would not be able to really ramp up that internal work if it weren't for our relationship with our emergency response coordinators, who really can see the big picture when we talk about these things and connect us with community partners to establish relationships that can lead to a sustainable path forward when we find ourselves in a situation where we need to put out timely communications in languages other than English. We also have ramped up our work on the legal epidemiology project that this board supported considerably. And I'm really excited to announce that we have, that Blake Frederick has accepted a promotion to Community Health Planner to serve as the coordinator of the legal epidemiology project. So that we have some dedicated staff capacity to making sure that we can build internal capacity to leverage this new and emerging skill set in public health. And then we've launched a contractual partnership relationship with some consultants to really explore the impact and importance of expanding our qualitative data capacity, the way in which we gather story and we use story and match story with qualitative data to tell a holistic picture of the impact of health disparity and the impact currently of infant and maternal loss. So that's an area where we're partnering closely with our health promotions section and their FEMR team to really find a way to strengthen and elevate the strong work that they're doing. We also have transitioned accreditation into the division. I think that I've mentioned that in the past. I see that as a great opportunity for us to make sure that health equity is embedded into every core measure and every operational section of the health department. It also serves as a great quality improvement identification platform. We can figure out those areas where we can grow and develop as we walk through the accreditation process, and then that naturally rolls into the performance management and quality improvement work that is currently starting to take shape and take form within the department that also sits within the division. We are exploring opportunities to seek outside consultation and support in re-energizing our PMQI efforts within the department. I think that as we now have emerged, I'm saying it from my perspective, we've emerged for the most part from our public health emergency. It's an opportunity for us to revisit and reinvest time and energy in our performance management quality improvement efforts. And then we also oversee the day-to-day operations of the CDC Public Health Infrastructure Grant Award that was received by our health department, with a primary focus, one of the key spokes or pillars of that being around workforce capacity development. And we recognize that requires us to take a hard look at some of the areas in which we support and onboard our staff in developing comprehensive and structured onboarding for each and every employee of the health department is a step that was built into our work plan as an action item for this grant. And then continuing to support ongoing workforce training and education to have comprehensive annual recurrent training so that we make sure that we not only onboard the highest quality public health professionals, but that we continue to develop those skills in our workforce so that we can retain the highest quality public health professionals within our department. And then most recently, the Douglas County Health Department's information line and the personnel that support that were transitioned over to the Division of Health Equity and Planning. We feel like that is one of the greatest unanticipated positive outcomes of COVID, that we were able to build out a new communication channel that can make sure that timely information reaches the community, and that it is a two-way communication platform so that members of our community can reach the health department and get accurate information or connected to the right resources without delay. So we felt like it was important that we build that into just into the foundation, the fabric of our department, so that it becomes capacity that is maintained. And we recognize that it's easier to maintain capacity than to have to try and build it back up when we step into another emergency. So the information line, it is the same information line. So we stood up a COVID information line. We recognized that it makes sense for us to maintain that and to broaden the scope of that information line. So as our call volume has decreased and the calls related to COVID directly have decreased, we still continue to see a need for direct channels of communication with our community. And so we've repurposed that to be a call center that can support our department broadly. I'm just going to really quickly point out some accomplishments. I might punt on the remainder of this so that Akshay can speak, but I'm happy to chat with any of you offline or in a following meeting about anything else that is built into this slide deck. I want to take a couple of minutes though to point out the accomplishments of the team that I have the pleasure of working with. Obviously, as a department, we have prioritized and continued to prioritize our efforts towards accreditation, recognizing it as a foundational step. It is important that we, as a local health department serving a diverse community, show up as an accredited health department. And it makes us better every single day. And we will continue to prioritize initial accreditation, and we will continue that drive as we pursue reaccreditation. I'm really excited to be able to announce that we have made an offer to an accreditation coordinator candidate, and they have accepted. So we're in the process of onboarding a new accreditation coordinator. That has been a long time coming. We've been waiting about 8 months to be able to onboard a new accreditation coordinator, and I've realized that I'm kind of a poor substitute for a fill-in accreditation coordinator. So we're excited for that. I also want to just speak to some of the work that Andy Wessel has been doing in developing an internal health equity assessment tool that we are working very closely with the Board of Health's Health Equity Committee to refine and transition it into a tool that can effectively give us a point-in-time view of how we are actually operationalizing both the resolution declaring racism a public health crisis and those very real 22 action steps that were written, but also just the foundational capacity and capabilities necessary to operationalize health equity in every aspect and corner of our department. I also want to speak to our work on qualitative analysis of the COVID advisory meetings. My team heard this board several meetings ago when we were asked how we are partnering with academic public health professionals to actually take the data that we are stewards of that belongs to the community and give it back to the community. It has not been a fast process, but we are still working through that. We are compiling typed transcripts of all of the COVID community advisory meetings that took place between our department in North Omaha and our department in South Omaha, so that we have accurate, comprehensive typed transcripts so that we can begin some thematic analysis so that we can identify what was communicated to us as the central themes, how did we respond to those or not, and how can we improve in the future. And lastly, I want to, and that is being led in large part by Blake. And then I last want to give a quick a shout out to Akshay and William at the health department for the work that they've been doing on a long-standing project that we have had going with our oral history project, where we have intentionally gained the story and experience of community members, but also members of our workforce as it relates to the Declaration and the impact that that has on our community and the very real and felt impacts of racism as a social determinant of health. We have, I just received what I view to be a really, really amazing abstract document yesterday, and I'm excited for us to be able to get that turned around in a format that is ready for presentation to all of you on this board. Just demonstrating our commitment to not, as stewards of data, to not be guardians of data, and to make sure that it returns to the people who honored us with it. So I'm gonna go ahead and punt now to Akshay so that he can present more specifically on gun violence and some of the potential strategies to mitigate that. I'm sorry.
I have a few questions before Akshay
that's
presents.
fine.
Sorry, Akshay. So you had mentioned the oral history project. I'm just curious. I've seen the project, so it's nice. But interested in how you're assessing the impact of this project, and like how is this helping to for us to achieve health equity?
I think that's a fabulous question. I think being able to do some thematic analysis of this, to identify the key themes that have emerged from people who have tremendous lived experience, and identify the areas where we are consistently being told the same things, the same barriers are impacting marginalized populations. It requires us to then embed that in our future action plans to address what we're identifying to be key untargeted themes. It also tells us those themes that have emerged in areas where we have really made measurable progress towards towards actually operationalizing something that is kind of nebulous. It's hard to describe how we're going to operationalize an action plan to address racism, especially, and it is easier when we talk about doing it through a public health lens and applying a public health perspective, but without being able to then have concrete examples from members of the community of ways in which we've had a meaningful and measurable impact, it's hard to say whether or not we have made any impact. So I think that being able to not only conduct these oral histories, but then now having been able to apply some thematic analysis to that to identify key and emergent themes that existed in the data that have been sitting there ready for us to see for a long time, but we have not had the capacity in the past to actually pull those out, is a really important first step. And that's where we're at.
Thank you. Are you planning to present that at the next board meeting or sometime before the end of the year?
I think we can probably plan to do it by the end of the year. Okay. Yes.
That would be great.
Yeah.
Last question, sorry. You had mentioned the qualitative analysis of the COVID advisory meetings in North and South Omaha. Of course, I participated in a lot of those North Omaha meetings. I'm just curious who you're contracting with to do the qualitative analysis and when that information will also be presented to the board.
Yeah, we want to be thoughtful and mindful. So at this point, we are still, to be candid, we're still struggling with getting the accurate transcription taken care of. And we want to make sure that we have those accurate transcripts ready for any entity that we would consider contracting with. We have reached out to academic partners to identify who may be the right people to do this analysis. We recognize that we're not, as a health department and my team, we are not well positioned to do this ourselves. We need we need experts who do this every day, and we will continue to reach out to you and other academic partners to identify places and people who might be the best source to do this next step of the work.
Happy to help.
Jamin, for clarification, when you refer to continued forward progress on accreditation, are you referring to the Public Health Accreditation
Yes,
Board?
I am.
And so does FAB then have a specific criterion for a health equity division?
So the current FAB standards, so standard 2022 or version 2022, they revamped their entire public health accreditation standards and measures, and they created a section specifically on health equity, and then they embedded health equity measures and key indicators throughout all of their core domains. That's the accreditation version that we are following. And so we are making sure that those standards and measures are identified and met throughout all of our operational divisions within the department.
And did I hear you mention you're bringing in somebody to help with this piece of it?
Yes, so historically we have had our own internal accreditation coordinator. We have typically had a community health planner whose primary role and responsibility is to drive our accreditation efforts. We've had, due to staff turnover, we've had a period of time in which that position has been unfilled, and we've taken that time to try and identify the right candidates, and we're excited that we've found someone who we think will be a great fit to our team, and are in the process of onboarding them so that they can continue to do what our past accreditation coordinators have done.
Okay, so this is a standing position.
This
within
is a
the health
standing position. I
department
think
that
we've had an accreditation
that
coordinator
Celeste?
for, it was, yes.
Okay. Okay. Okay.
Or you might, because you got to get on the mic if you answer it.
So in the past, Celeste was our accreditation coordinator. We then had Jesse, and then we have continued the work. And even though we've had some staff turnover, the work has continued. And I have served as our acting accreditation coordinator. I've relied upon my team quite a bit for that. But we have a good path forward where we have adopted a kind of an all-hands approach throughout the department. In the past, it has been sort of a top-down approach. So now we have accreditation domain team leaders who make up all levels of our staff throughout the department, who are leading their own. I'm sorry, there are 10 modules, there are 10 domain areas, and so each of those domains has a team leader that is a representative throughout our staff, and then they have developed their own internal teams to drive towards identifying documentation for that domain. So,
Thank you.
I have a quick question about the storytelling project.
mm-hmm.
Can you speak a little bit more about how you're going to plan to share and utilize those stories and make sure that they have an impact, as well as how you're identifying and approaching kind of those subjects whose story you're going to tell sensitively?
Absolutely. I think, one, we've recognized this is a great opportunity for us to demonstrate our role as a convener. I think oftentimes we show up and we think that our job is to facilitate and own and drive everything. We have a great opportunity to, leverage the infrastructure dollars that we've received in a way that we can then just convene and hold space for a steering committee of community members to identify who needs to be present, whose stories need to be the stories captured, and then how do we, in a sensitive way, how do we honor that story and make sure that others hear the story, and so that's, I think we are we are not far into the process. A lot of the questions you have are standing questions that we have as well, but we recognize that without first engaging with community members and representatives throughout the unique communities that make up Douglas County, we won't be able to answer those follow-on questions. So we are working intentionally slow to identify the right people to make up the steering committee that will work alongside the consultants to do the work.
Thank you.
I have one more question. Sorry, I know you're trying to get to Akshay. The accreditation process, I know the last time when Celeste was the coordinator, there was a timeline that we had to be, I guess, meeting. Obviously, that timeline is out. What's the new timeline for us to be accredited? Because I know that they do it on a certain basis.
So there is a strict timeline. So we are so the process involves first submitting a readiness assessment to the Public Health Accreditation Board so that they can gauge how much support they think you're going to need in getting there. And then that is followed by the submission of an initial application. And once you submit the initial application, that starts the clock. And that from that point on, you have 12 months to identify and compile your documentation to be submitted. And then after that, you will have a site visit and then an additional 2 months to make any amendments or additions to your documentation.
So all the efforts that we made last time, because I was also a part of that, we have to start over with the new coordinator, or
No.
do we still get the chance to keep going?
No, we can continue to move forward.
Okay,
Most
that's
of the documentation that was compiled in the previous iteration either continues to fit those core measures or just needed some tender loving care from our team to make adjustments so that it still is relevant and fits. And so that's really the work that the domain teams have been doing. They've been identifying what still fits, what elements need to be revisited. For example, our public health communications plan. That's a document that's living and active anyways and should be revisited. And it was no longer a relevant document after we stepped into a public health emergency. Things needed to change within it. We made those changes, and by doing so, we just needed to document that we had made updates to that, and then it remains a relevant document for us.
So we're not at the 12-month clock stage, or are we?
We have good bittersweet news. We thought that we were at the stage where all documentation needed to be submitted by the end of November. What we've identified is we actually have a little bit more time because in past years the readiness assessment was used as the application, and in this new version, they split them out so that the readiness assessment and initial application are two separate tasks. We submitted our readiness assessment and started our own internal clock, thinking that started the 12-month clock. And what we identified was that we failed to submit the application, which is not a bad thing. But in submitting the application, which will go in the middle of October, that actually starts our window, extending our accreditation window to 12 months from 12 months from October. So, and we still can submit all of our documentation early, and we anticipate that we'll be able to do that because we have compiled the majority of it. So,
Thank you. I'm done.
Jamin, I didn't see this somebody can send us this presentation because I didn't see that. Okay, all right. You're up.
Good morning, everyone. My name is Akshay Selva-Kamaraj, and I'm the health equity epidemiologist at the Douglas County Health Department. And it's my pleasure to be in front of you all this morning to talk about the current climate around gun violence here in Douglas County and the potential effectiveness of promoting safe storage methods for firearms, specifically gun locks. I'll begin with an overview of gun violence statistics here in Douglas County and compared to the United States. And I'll touch briefly on the potential brief complications that we face in combating this issue. And then I'll transition to types of safe firearm storage methods and the effectiveness of each in effectively reducing firearm rates of violence. And lastly, I'll finish with a quick analysis of previous attempts at gun lock distribution programs and the potential limitations that are associated with them. Looking here at the data from 2019, we see an interesting discrepancy between the rates of homicide to suicide between Douglas County and the United States. We see an alarming rate of almost 3-to-1 suicides here in Douglas County, whereas in the United States, that ratio is more closer to 1-to-1. In this statistic, both homicide and suicide are classified as intentional firearm-related injuries, and the other in the statistic refers to unintentional firearm-related injuries, which makes up a smaller proportion of the overall statistic. It is important to distinguish between the difference of unintentional and intentional firearm-related violence because the effectiveness of safe storage programs can vary drastically between the two. In the United States, children aged between 10 to 19 are at the highest risk for unintentional firearm death. And between 2016 to 2020, there were 7 instances of unintended firearm-related shootings in Nebraska by children. On the other hand, suicides fall under intentional firearm injuries, but studies have also shown safe storage methods can positively impact high suicide rates. The races that are the most affected by firearm death by suicide are white, American Indian, Alaska Native, and Black populations. And males are the most affected, with the age range of 75 plus being the most susceptible, and men aged between 20 to 34 following closely behind. We face many challenges that harm our efforts in reducing these levels of gun violence. In the United States, half of suicide deaths are due to firearms. And with guns being present in nearly a third of all US households, this level of access to firearms is associated with an increased likelihood of injury or death. And this is compounded by the fact that 54% of gun owners do not practice safe storage methods at all. But this gives us an opportunity to highlight the potential effectiveness of gun locks and other safe storage methods. There are different types of safe storage methods for firearms, one of which is simply unloading a gun, removing the ammo, and keeping each individual piece separate. Others are gun safes or gun boxes, which is the option most preferred method by firearm owners when considering safe storage methods for firearms, and the minority preferring trigger locks or cable locks. Trigger locks work by preventing unwanted firing by attaching directly to the trigger mechanism, and cable locks work similarly by attaching a rubber band through the barrel of the gun, preventing unwanted firing. As we can see, multiple studies have shown that proper firearm storage can help in reducing unintentional firearm-related injuries as well as suicides. And it's also noted that safe storage of guns can be effective in reducing impulsive suicide acts, where they can create critical life-saving moments. There is a compelling evidence that suggests a considerable proportion of suicides are impulsive acts. And the extra seconds or minutes that gun locks can create before a gun becomes usable can be imperative in saving lives. But just to clarify, the data and studies are strictly in reference to unintentional firearm-related injuries and suicides. There have not been enough studies conducted to make the same relationship with intentional homicidal firearm-related violence. There have been programs that have promoted gun locks to various different communities. They often work with local police departments and health clinics to educate the public on safe storage practices while distributing gun locks for free, which greatly increases uptake. Studies also show that when gun locks are given for free, almost 80% of gun owners who have considered safe storage practices improve safe storage at home after completion of the program. However, if gun locks were not offered for free, improvement in safe storage reduced drastically. Despite the potential positive effects that gun locks can bring, they come with their own set of limitations. The main reason for the low uptake of gun and trigger locks is due to the large amount of time and effort needed in order to access a firearm in a situation of need. 75% of gun owners prefer safe storage methods that emphasize speed of locking or unlocking a device. And for this reason, trigger locks and cable locks are the least preferred method of safe storage, followed closely behind by biometric and individual lock boxes. It is also unfortunate to see that close to 50% of firearm owners who do not practice any safe storage continue to believe gun locks are not necessary following study participation. From the studies and data available, gun locks show that they can have a positive impact in reducing suicide rates and unintentional firearm-related injuries. However, they don't address the underlying causes of the high suicide rates that we see in our community. I think it would be important to supplement any gun lock distribution programs with interventions that affect the mental health in our community as well. Thank you.
Ashe, can you go back to slide 1?
I'm sorry?
The first slide you showed.
Mm-hmm.
Third one then. Okay, take some time and go through this again.
So the rates of homicides to suicides we see here are close to 3 to 1. And this is just strictly from 2019. And the ratio, as we can see, is quite different from the rest of the United States. There are a few other states that have similar rates of high suicide levels to homicides, including Wyoming, Montana, and Alaska. Is there anything else that you'd want me to say about the statistics?
So basically, so back me up on this. In 19, there was a point where Omaha, largely, I'm saying Omaha, but Douglas County, because the area was almost didn't have a gun homicide. But I'm assuming, I forgot, there's a stat that the chief and at the time city council member was stating that we were at in 19 to a point in the year in regards to gun violence. So I'm just trying to add up how that homicide number matches where it came from, because basically what you're saying is from this, we're below the national average on gun homicides, but the suicides, we're way above. And I just want to make sure I'm good on this, you classify the suicides as intentional.
Suicides and homicides, they're both classified as intentional firearm-related violence.
Okay, what's classified as unintentional again?
Unintentional is children accessing firearms when they aren't supposed to, or hunting accidents. They would all classify as unintentional.
Okay, is that other?
Yes.
Okay. Well, I was trying to explain this, but it's not matching up when I'm seeing it. I'm wondering I'm just curious, where did the 41 gun homicides? I'm just curious where that came from, because I know I had heard a stat, and I heard Schmatter and Councilman Gray at the time saying that there was a point where Omaha had not experienced almost got through a period of time without a homicide to some degree. So that's just why why I'm not bothering, but I'm trying to add up in my head. But
I'll have to double check my sources then and look back at that and get back to you.
Okay. Regarding the suicide numbers for Douglas County, do you have any information on race and age of those that completed suicide?
I'm sure that data is available, but I don't have it on me right now.
Okay. I'm just curious, who is committing suicide? I know what you said nationally about 75 and older, 20 to 34 males, but just curious in Douglas County, what's that demographic or characteristic profile look like?
I believe that white males are the most affected by suicides here in Douglas County as well, but I'll have to double check on that and get back to you as well. Yes.
What of the 50% about homes that don't practice safe gun, control? What do you think besides they're just saying it's not necessary? Is there anything else driving that lack of wanting to keep their firearms safe in their home?
The main reason is specifically due to the speed of access of firearms, gun locks, and putting guns in safes. Firearm owners feel like that limits their ability to protect themselves in situations of need where they would need a firearm.
Your research, I think, focused on safe storage methods and mechanisms. And it sounds like what you're experiencing in our communities is that hasn't been a voluntary or an educational type effort. Is that an accurate thing to say? Or is there any kind of measures or local laws that communities are passing to encourage these things too?
In Nebraska, from what I've seen, there are no laws, but I know in, I think it's Lancaster County, is that where Lincoln is? That they created a program through their local sheriff's office for any gun purchases for gun locks to be distributed with them. But typically, yes.
Okay. And then did you research any other mechanisms or opportunities to reduce gun violence that were in addition to safe storage opportunities?
No, this one was just specifically for safe storage.
Okay, thanks.
I would really like to see, I know there's been a lot of initiatives with mental health in our community. I would really like to have you back and do a presentation and look at our actual numbers now versus the 2019 numbers and see if that's made a difference. Because I do believe that a lot of our mental health initiatives are focused in women and children. And as you pointed here, our suicide rates are focused in the male population and the white population. So I really think that we need to address that and see if there's been any change with the mental health initiatives from 2019 to 2023-24.
Yeah, I'd be happy to do so.
Thank you.
I'd like to add to that too. I agree with Celine. I also know that before the pandemic, suicide rates among our youth was incredibly high here. I know we struggled to get the schools to opt in to taking the BRFSS, which helps us to assess that. So I'm wondering where we are, if we're going to revisit that, because I think it's important. Suicide is still an issue among youth. And so I think in addition to what Celine mentioned, we should possibly add in some information about what's going on with youth in terms of mental health status from 2019 to now.
Yeah, of course. I feel like that would be an important part to talk about.
If I could add just a few things. So first, I wanted to make sure, so the targeted scope of this presentation was due to a specific request to look at the efficacy of gun locks and gun safe storage and any potential relationship that had on gun-related violence. So I think there is definitely a lot of other areas where we can explore. We were responding to a very targeted request and trying to apply both a literature review and a view of what is publicly available data to kind of paint a picture, and recognizing that oftentimes mortality data does lag.
So just for this, Ashe and Dr. Hughes, I guess, can we, I'm assuming, it's public now. Can you send this out to the board? And can we note that up on that administrative meeting that we have set on the calendar for the first Friday? And then just add, for the two topics, this further discussion, and then I guess any other questions people may have for Jamin on accreditation. And at least if you can send this out, this will give everybody a chance to chew on it, and if people want to attend, go, but we'll dig into this a little more and see how it ties, because the two things I guess I'm getting out of what you're saying is, I know at one point there were times where people were giving out free gun locks in certain states. This was before you had permitless carry and things of that sort, but from what I did get out of what you were saying, without having to chew on it more, there is some reduction in giving out free gun locks, but you would advise that not be the sole effort, that it also be affiliated with increased mental health education and access and other things of that sort. But there definitely seems like there's a little more dig in there. But
Right.
I guess we can use that Friday to get there. Okay.
Yeah, gun locks can show an effective reduction in unintentional and suicide rates. Yes.
Yeah, because I'd be interested to have before we had that meeting there, because my understanding at one point, I had heard from the police department that at least locally, car thefts out of guns was one of the big deals in regards to the entryway in of illegal guns, the car thefts out of guns, some thefts through cross kind of state transport, but then also it was that the big incident that happened at one point with the gun store getting robbed here locally. So I'd be interested to see what making those available would possibly do and what the feasibility of doing that is.
Yeah, of course.
Okay. Questions? Okay.
Thank you, guys.
Thank you. So for just anybody that knows, we'll be meeting on the, I think it's the 7th, probably of October. I think that's the first Friday. This will be on for further the 6th. No, it's the 6th. Yeah, the 6th for further discussion. So we'll make sure we note that. Any other questions? Any questions on the reports that were distributed? I got one question that I want to before we. You got any update on where you think things are going to fall with potential budget cuts that you would think the 14K that may come because of the Fed budget agreement? I know they're in a whole nother piece, but is that still what you're projecting, the 400,000 cut in regards to federal money?
Are you talking about the cuts that came from
Yeah.
the debt ceiling bill? Yeah, we're at this time we don't have exact numbers, but also we don't have any reason to think it's changed.
Okay.
So it is still where we're sitting, and we are exploring a couple of different options to stabilize that. So it's a little bit of a.
But until it's final, that's just still what you're anticipating. It could,
Yeah.
Okay.
Yeah, we don't have a whole lot more information to give you on that just yet.
Okay. All right. With that, if there's nothing further, is there a motion to adjourn? Motion by Wilkins, is there a second?
Second.
Second by Festerson. Roll call.
Yes.
Yes. Thank you all. Thank you all.